Sıradaki konuşmacımız.
Hello, everyone.
Thank you, Mr. Lang. How are you?
Do you hear me?
Yes, we can hear you.
Okay, thank you very much again. My talk or my video is an open procedure. It is extended left hepatectomy in a patient with intrahepatic cholangiocarcinoma, where we did resection of the hilar bifurcation and resection plus reconstruction of the right hepatic vein. You see here the history of the patient. It's the case. It was a 50-year-old man, a huge and tall man, 180 centimeters and 112 kilogram. He was in very good physical condition. He was a little bit jaundiced. Bilirubin was 4.2, but he had no cholangitis. And the tumor was located centrally in the liver. It was an intrahepatic cholangiocarcinoma with infiltration of all three liver veins, and the need for reconstruction of the right hepatic vein. And also we had to resect the hilar bifurcation and to reconstruct several ducts. At that time, it was in 2014, we did not yet use a neoadjuvant chemotherapy for downsizing. At that time, we went for upfront surgery. You will see the CT scans. You see here the centrally located tumor. He reaches the right hepatic vein. The left and the middle hepatic vein were in the tumor. You can see here the left portal vein, the tumor centrally located, reaching also the caudate lobe. And the patient has a trifurcation of the portal vein, or you can say has a bifurcation, but he had a right posterior branch leaving the portal vein before the bifurcation or prior to the bifurcation. This is the video of the CT scan. Here the tumor centrally located. Again, the CT here with the tumor reaching the right hepatic vein for about 5 centimeters. These are the best slides we have because the patient was so huge. It was the best thing we could get. Again, here the slide, you see here the dilated left hepatic ducts, and here the tumor almost surrounding the hilum, going down to the vena cava and going to the caudate lobe, and also a dilated posterior segmental bile duct in the right lobe. So these were the CT scans prior to operation, and then I show you the video of the operation. See, the liver is not jaundiced, but it is a huge liver. We start with mobilizing the liver, taking down the triangular ligament on the right side. You see my co-worker, he had to do a very tough job because the liver was huge. And then we encircled the right hepatic vein. This is preparation in the hilum. The patient had huge lymph nodes, you will see. These are lymph nodes in the hepatic hilum. They turned out to be negative, finally. Now, then we encircled the inferior hepatic vein to be able to do total vascular occlusion. The patient had an inferior right hepatic vein. We preserved initially, but later we took it down. And then we freed the vena cava completely. Now we encircled the suprahepatic vena cava, so we were ready to do the complete vascular occlusion. We took down the bile duct. This is the package of lymph nodes. It was lymph node negative. We didn't expect, but it was negative finally. This is the common hepatic artery. The patient had also 2 arteries to the left. This is to segment 2 and 3. We took it down. And this is the segment 4 artery, which we also took down. And then we taped the portal vein. branch to the left, but also the main portal vein, and you will see soon also the posterior portal vein. So right is portal vein, main portal vein, this is left portal vein, and this here is the posterior. And then we took down the left portal vein. The tumor was close to the portal bifurcation, so we clamped this with bulldog clamps, cut very close to the main portal vein. Usually we leave a stump, but in this situation it was not possible, so we reconstructed a little bit. And this is left and middle hepatic vein. We could free it. You see it is a huge liver, only a little bit jaundiced. And now we mark on the surface the cutting line. We did this operation under intermittent portal vein clamping. We did it for 7 times 10 minutes. Now we see that the liver is a little bit jaundiced, but not too much. We always clamp for 10 minutes, then we open for 5 minutes, and then continued with the resection. These are some branches going to the left side. We took them down. Now we incised behind the hepatic hilum because the tumor was a little bit encircling the hepatic hilum. This was not so easy and was unusual to do the preparation this way, but we had to do. And then we had to take down intrahepatically the biliary tree. Finally, we ended up with 4 bile ducts to the right posterior sector. And now we are slowly approaching the right hepatic vein. You will see soon. We are already close to the vena cava. And now we have reached the right hepatic vein. This is the right hepatic vein. And now we did total vascular occlusion. We clamped the hilum and also the vena cava below and above the liver. And then we partially cut the right hepatic vein. We did not completely resect. We only resected one part of the wall. And at the end, the right hepatic vein, you see it here, it was like a gutter. So we had partially the wall, but most of the wall was resected. Now the right hepatic vein is completely resected. We did the clamping of the right hepatic vein, so we could now release the vena cava. It's only total vascular occlusion of the liver, but the vena cava is free, but because we clamped here. And now the specimen is out. We never use the staplers when we cut the veins. We always transect open and suture it. And now we had to reconstruct the right hepatic vein. You see it here. It was about 10 centimeters what we had to reconstruct. And we used in this operation bovine pericardium. You can also use the venous flap, maybe also use peritoneum. At that time I did not use peritoneum. Nowadays I use peritoneum to reconstruct veins. So we had to reconstruct almost the entire anterior wall of the right hepatic vein. Here is only a small rim of the posterior wall. See here the clamp on the right hepatic vein. The vena cava is open. The patient is completely stable, hemodynamically stable. Now it still looks very nice, but you will see later that the pericardium is a little bit rigid. This is very nice, but here it's not so nice, but it's okay. Then we opened. It was okay. It was the only vein we had. You see here. Then we did an ultrasound. You see here the probes, metal probes in the bile duct. This ultrasound of portal vein and artery. And this is the hepatic vein, and it was okay. Then we reconstructed the biliary tree, and this was done by 4 anastomosis. We reinserted each bile duct separately, and we did it with solitary stitches. No running suture, solitary stitches, 4 anastomosis. And this is the final cetus with the reconstructed right hepatic vein. This is the specimen. And final histology was a PT2 tumor. All lymph nodes were negative. This was surprising. No lymphatic invasion, no vascular invasion, so the right hepatic vein was not invaded. We did not expect this, but this was very good. G3, no metastasis, and it was an R0 resection. So this was very fine. The post-op course was also very fine. The patient recovered very soon, could leave the hospital after, I think, 7 or 8 days. This is CT scan at 3 months. Everything is fine. The patient was fine. And this is the further course. The patient developed intrahepatic recurrence 7 months after resection. You see it here and here. There were 2 tiny metastases, 2 new intrahepatic cholangiocarcinoma. This was treated by TACE. And we also gave chemotherapy, gemcitabine and cisplatin. We had a partial remission. Then ablation percutaneously. Then again recurrence, again chemotherapy, a CIRT, and finally folfoxiri. The patient died a little bit more than 3 years after the resection. I thank you for your attendance. Thank you very much.
Thank you, Mr. Lang, for your excellent presentation. Soran varsa buyurun sorabilirsiniz.
Please.
Okay, Mr. Lang, thank you very much. Okay, we can.
Thank you for your contribution, and we thank you again for your excellent work and videos. There isn't any question for you.
Okay.
Everyone is shocked and very surprising, excellent operation. There isn't any questions anymore. Thank you very much, Professor Lang.
One comment from my side. Nowadays we would do give neoadjuvant chemotherapy to downsize it a little bit. And probably we would not use bovine pericardium, but we would use peritoneum. But everything else we would do the same. I thank you for the invitation.
Thank you very much.